Okay, when working with pediatrics and fluoroscopy, there's certain things that the state says you need to follow. So the objectives describe ways in which to minimize motion for pediatric fluoroscopy, list personnel and parental protection techniques during pediatric fluoroscopy, apply gonadal shielding when appropriate, and identify the effects of automatic exposure control problems that may occur when working with the peds. And so, when we're working with pediatrics, as you know, we've got to be really quick so we can cut down on their radiation dose and keep motion out of the images. So typically, pediatrics have less radiation than adults for the equivalent study. The problem is the longer lifespan of a child allows more time for manifestations of long-term effects of radiation. So if we look at Burgonese and Troubadet and their theory, so children are more sensitive to radiation due to high mitonic activity. So the cells are rapidly dividing, so they're obviously more sensitive to the radiation. So we want to keep it as low as possible whenever we're doing fluoro on them. So motion. Motion accounts for more imaging problems than for adults, of course. So we need to establish some kind of rapport with the child that's friendly and try to win them over for their cooperation. So a lot of times we'll practice the exam and practice breathing and practice the positions before we actually go through it live with fluoro. There are times where we need to sedate the child or use full anesthesia. So there are different immobilization devices. So they secure the infant and the small children. So they range from simple boards with Velcro, like I hate the name, they call them brat boards. There's also the Picostat. There's more complex positioning aids, which allow for a variety of positions and to move the child into different angles. If you can use sandbags, and compression bands are useful also. So, severely ill children and infants may need a sterile environment. And this is difficult because then when we're dealing with sterile conditions, we can't use any kind of immobilization. So, there are times where we can't always use sedation either. So, we have to physically restrain the child or infant. The problem is the scatter radiation is high, so be sure that you wear at least the lead apron. You should have gloves on in addition. Gonadal shields must be at least 0.5 millimeters of lead and must be worn whenever possible, as long as it doesn't interfere with the exam. And the genetic effects of radiation are thought to be cumulative, so throughout their lifetime, so we need to protect them and their offspring for years later. Since we're using such a low technique on the kids, artifacts show up that wouldn't normally show up when we use the same on an adult. So we look at their clothing, bandages, their diapers, all of that shows due to the low technical factors that we're using for the kids. So make sure you remove all articles of clothing. So ABC and ABS, choosing the correct technique is hard on kids. Why? They're different sizes and different thicknesses. So ABC is not, if it's not functioning properly, it could be because the child's not covering the complete eye. And so you're going to have to set a manual technique or collimate down to the child's size. Infants are very small children may not be possible when using your ABC. Also, when using ABC, be careful not to put the barium right in the center of the eye, as it will drive the technique all the way up to max, trying to penetrate that barium. So be cognizant of that. So your distance. So shortest possible patient to image intensifier should be used. As you know, we did the lab. So longer distance as radiation to the patient and the operator increases. So increasing distance also increases motion in penumbra. Blur. So other things to consider, so use the smallest possible beam size. So small increases in beam size can increase dose. Collimate to the anatomical part only. Keep cine frames to a minimum. Do not use a grid. So make sure when you're doing pediatric fluoro that the grid is not in place. Make sure it's retracted back. And use spot film cameras and digital photospot cameras in lieu of conventional spot films. So that's it for pediatric. Let's roll into our mobile fluoroscopy equipment. So our objectives is to describe the type and structures, structural shielding that is required for mobile fluoroscopy procedures, recall the equipment provisions for mobile C-arm, and use image storing, video disc recording to reduce patient exposure. Okay, so structural provisions. So structural shielding requirements are minimal, if any. So the entire beam is pretty much intercepted by the image receptor. Regulatory provisions should be noted, though. When mobile equipment is being used routinely in one location, shielding must be provided as for a fixed install. So if you're just using it in the ER over and over and over in the same place, you have to actually provide the protection like you would if it was installed in that room. When mobile equipment is routinely used in operating rooms, appropriate structural shielding must be provided for these rooms. So basic regulatory provisions, so inherent provisions must be made so that the machine cannot be operated at a source to skin distance of less than 30 centimeters, which is 12 inches. A spacer attached to the X-ray tube on a portable C-arm fluoroscopy unit must limit the minimum X-ray source to patient distance to 12 inches, and the image intensification must be provided. Conventional fluoroscopy screens are not permitted. It should be impossible to create a fluoroscopic image when the collimator cone or diaphragm is not in place, so that's spacer. And it should be impossible to energize the useful beam of a mobile fluoroscopy unit unless the entire beam is intercepted by the image receptor. So the maximum permissible dose rate of 5 rads per minute may not be exceeded as measured at 30 centimeters from the input screen of the fluoroscopic image assembly. Personal monitoring is required for all persons operating mobile X-ray equipment, and protective aprons of at least 0.25 millimeters of lead equivalent must be worn if one is likely to receive 5 millirads per hour or more. So, orthopedic and urology and some cardiac procedures, users may incorporate an image storage disc recorder with an electronic radiography for reduction in patient dose. Boost. Boost will increase to maximum X-ray level. So use normal mode to locate the area of interest, and boost mode only when necessary to achieve the image quality of the image that is required. So the C-arm with manual exposure control, the operator to monitor the X-ray tube current and potential, the measurements of the table or the patient exposure rate shall be made at least once a year for units with automatic exposure control, and once every 3 years for units without the automatic exposure control. Immediately following the alteration of or replacement of major components like the X-ray tube or exposure controls, the image assembly or power source, so you have to bring a physicist out at that point. Okay, so